2 minutes ahead. We should start in exactly 6 minutes. I suggest, but you decide.
For me,
6 minutes. Okay.
For me, it's okay whenever you want.
Okay. Now we have 10 participants with us, including us.
We normally have around 30 and 40, so maybe you should wait.
Yes.
Maybe
some minutes. So,
Okay.
Lucas, you are in New York now?
Sorry.
You are in New York. Did I hear you well?
Once again, please. Hello, Mariano. Are you here? We don't hear you.
There's something wrong in the connection, or at least in mine. I don't know what's going on.
Okay.
Do you hear me well? Do you hear me?
Now, yes, we can hear you.
Okay. Are you in New York, Lucas? Did I hear you well?
I'm in New York, the States in New York. Yeah.
Okay. Are you in a congress or a meeting, or?
I have been in Atlanta visiting a new hospital in Atlanta upon the invitation of Andrew Reisner. And maybe you saw these photos in some of these groups. He posted these photos in some groups, and then I went to Houston for CNS and Masin meeting. And now I came here. I now have some obligations here in Columbia University. Today I'm opening the Cátedra for Serbian Language, Tradition, and Custom on Columbia University this afternoon.
Congrats. That's very good.
Yeah. Your sound is a little bit interrupted and a little bit late.
Oh, I'm sorry. I don't know. Maybe it's my Wi-Fi connection. Anyway, I'm not going to speak. You will. So.
No, that's okay. You can hear me well, right?
Yes, perfect.
Yes, we can hear you perfectly.
Great.
And you, Carlos, you're in Mexico now?
Yes, now in Mexico City. Exactly.
Okay. The only 2 days you are in Mexico this year.
No, 5 days.
Are you coming in Sofia?
Yes.
Of course.
And see you, both of you, in Torino, right? In Aracas?
Torino. Yes, exactly.
Yes.
Perfect. We are now 15.
15.
Yeah.
Who is hosting this, Mariano? You or somebody else? Who is hosting this in terms of Zoom platform?
Oh, it's Imad. Imad is here. It's the assistant of Professor Sharif, Salman Sharif.
Okay.
He's hosting he's been working with us since the beginning of these activities.
Okay. Okay. People are
You want to start?
Yeah, whenever you want. People are joining.
Yeah,
Okay.
Please. Yes.
Okay.
Carlos, please.
Well,
can I share the screen?
Yes. Well, so good morning from Mexico City to everybody. Welcome to this webinar series of neuroanatomy. Today is my pleasure to introduce to Dr. Lukas Rasulic. He's professor of the Faculty of Medicine at the University of Belgrade, head of the Department of Peripheral Nerve Surgery and Functional Neurosurgery at the University Clinical Center of Serbia, and the last former president of the WFNS Peripheral Nerve Surgery Committee. So today he will talk about the anatomy of the axillary nerve and its surgical approach. So Lucas, go ahead, please.
Hello, everybody. Greetings to all. I hope that you can hear me well. Carlos, thank you for this kind invitation. Mariano, congratulations for this continuous initiative in education in peripheral neurosurgery. This is our keep on rolling mission, and I am entitled today to speak about the anatomy of the axillary nerve and its surgical approach. This is one of the webinars in the series which is regarding to the anatomy of each individual nerve, each individual element in peripheral nerve system. And as all of you know, knowledge of the anatomy, morphological anatomy and topographical anatomy is of outstanding importance in dealing with all surgical aspects. So I hope this lecture will be useful to the listeners. Anyhow, a group of very devoted people from all over the world, small group of people, which is dedicated to peripheral neurosurgery. 3 of them you can see today in this webinar. Dedicated some time of their life in terms of education and promotion of the importance and raising an awareness about peripheral neurosurgery. And this initiative is part of their these activities as a continuous mission and task list competition in terms of educating young neurosurgeons all over the world in the field of peripheral neurosurgery. This is a functional priority number 2. So maybe somebody can say number 1, but both of them are 1 and 2. Musculocutaneous and axillary nerve are functional priorities in reinnervation in brachial plexus traumatic lesion. No matter of the surgical procedure and the type of surgical intervention, this is something we are striving to reinnervate as a mandatory activity in all surgical repair of the traumatic brachial plexus lesion. That's why, in between, that's why anatomy of the axillary nerve and the surgical approach is very important to know, because lesions of the axillary nerve can be isolated, which is very, let's say, sensitive in terms of evaluation and surgical intervention, and can be a part of the traumatic brachial plexus injuries in a full capacity. So I don't have nothing to disclose. These are basic anatomical consideration regarding axillary nerve. As you know that axillary nerve originates at axillary fossa, contains fibers from the C5 and C6 roots, and exit the fossa by entering the quadrangular space, and divides into 3 branches: anterior terminal, posterior terminal, and articular. This is something which is standard anatomy of the axillary nerve and its clinical importance. There are many references in the literature about this morphological anatomy, and in the textbooks of the anatomy you can find this as a classical description of the axillary nerve and its basic anatomical consideration. So axillary nerve is a predominantly motor nerve. His motor function is shoulder abduction, internal and external rotation. Axillary has also sensory part, and his sensory function, sensory innervation, is upper lateral cutaneous nerve, lateral and inferior shoulder, in terms of sensory innervation. Axillary nerve gives also articular branch, which is innervating glenohumeral joint. Motor part of the axillary nerve, which is divided in anterior and posterior terminal branch. Anterior terminal branch are winding around surgical neck of the humerus, and its motor innervation is deltoid muscle, anterior 2/3, and sensory innervation anterolateral shoulder. Posterior terminal branch is related to the motor innervation to the deltoid muscle, posterior 1/3, and the teres minor muscle. And sensory innervation are to the lateral inferior shoulder. This is also very important issue in knowledge of the anatomy of the axillary nerve. Not only axillary nerve, intraneural topography is very important to know about in regards of any nerve which is part of the target of for the reinnervation. So this is C5-C6 origin of the axillary nerve. In some circumstances, some contribution can be from the C7, but it's very low. But generally speaking, this is intraneural topography in terms of cranial caudal and ventral dorsal relations from the origin of the fibers from C5-C6 who are in charge for axillary nerve. And you can see this is in the C5-C6 roots in his position, which is cranial to dorsal. Number of the fibers in the axillary nerve can have certain variations, but generally speaking, you can see here on this table the axon counts in the main trunk, in the anterior branch, in the posterior branch, teres minor branch, and superficial branch, as well as to the generally to the axillary nerve. So this is very important to have in mind in terms of understanding of the mechanism of the injuries and in terms of reinnervation procedures to the axillary nerve. This is another important issue in the anatomy, which is very, very important in terms of not to miss axillary nerve, because there are some certain original variations of the axillary nerve, and axillary nerve can origin as a common trunk with the thoracodorsal nerve, lower subscapular nerve, or upper subscapular nerve. And you can see here some photos. It can originate from the different elements as a terminal branch of the upper trunk. It can origin as a side branch of upper trunk, posterior division, middle trunk, posterior division, as a joint branch with upper trunk, both divisions, and middle trunk, anterior divisions. So these are variations which can be very rare, but then some of them are more frequent. And generally speaking, this is something what somebody who is exploring the brachial plexus always have to have in mind, since this is this can be a potential misleading to in terms of reinnervation. These are anatomical basis of the variable aspects of branching of the axillary nerve, and as you can see, there are more than several variations in a number of branches, in the level of origin, in the type of branches, in the target organ innervation, and this is also related to the anatomic branch pattern to the axillary nerve. And as you can see here, it can be like frontal type, posterior type, mixed type. So this is something also which is related for the reinnervation of the axillary nerve. Pathway variations of the axillary nerve. These are terminal branching in the axilla. Then axillary nerve pierces the subscapular muscle. Then idiopathic aberration of the axillary nerve pathway, which can be in coursing variations in the different type of this anatomical characteristics. This is something which you also have to keep in mind in exploring the axillary nerve. This is a high resolution imaging technology, which is ultrasound and MRI, high resolution 3 Tesla MRI. This is some images in terms of neurography of the brachial plexus and these branches with emphasis of the 3D imaging. You can also can find axillary nerve in this projection. Nowadays, we have on disposal this cadaver-free education in terms of 3D understanding of the topographical, morphological relationship of each individual element. And this is some examples of the virtual 3D anatomy of the axillary nerve from its origin, following his course to his end organs. And this is dysfunction. So lesion of the axillary nerve can be isolated, included in upper brachial plexus palsy, which is C5, C6 origin, upper extended brachial plexus palsy, this is C5, C7 origin, and complete brachial plexus palsy, which is C5, T1 origin. And these are some clinical examples how this looks like. Generally speaking, the decision-making process is choosing the right surgical strategy is tailored to the individual patient, and depending on the level and combination of the morphological lesion of the brachial plexus, is it avulsion or only supragangliar, or combination with supra and infraganglion, or the same on different level of origin of the fibers. But generally speaking, if we're focusing to the axillary nerve, this is these are some clinical examples, and you will see now some anatomical aspects of the classic standard surgical approach to the axillary nerve. So key landmarks for the classic anterior deltopectoral approach to the axillary nerve, which is standard part of the infraclavicular approach to the brachial plexus, are cephalic vein as a guide to the deltopectoral groove, clavipectoral fascia covering the infraclavicular brachial plexus, and it exits under the tendon of pectoral minor, lateral brachial plexus cord, and axillary artery. The pectoral major and pectoral minor are cut or retracted to view the infraclavicular plexus, and it is included into, as I said, into infraclavicular brachial plexus exploration. Another approach is axillary approach to the axillary nerve, and the key landmarks in this approach, which are forming a triangle surrounding the axillary nerve, are latissimus dorsi tendon laterally, posterior humeral circumflex artery superiorly, and subscapular artery medially. There are some advantages of this approach, which means it allows access to the distal part of the nerve, visualization of major blood vessels, and no need for a muscle section. And disadvantages are limited access to the proximal part of the axillary nerve, which is behind to the pectoral minor. And posterior approach to the axillary nerve with key landmarks, deltoid muscle, long triceps head, and teres minor. Advantages are more comfort and less complication compared to the incision to the axilla. If usually there are no injuries of that part and no scar tissue, so if you are dissecting through the anatomical planes, and it's quite elegant, you can find the axillary nerve in the within this posterior approach. So these are some surgical photos and videos which are now presenting these surgical approaches and anatomical characteristics. This is anterior deltopectoral approach to the axillary nerve, patient positioning and skin incision. This is something, as I said, that part of the infraclavicular brachial plexus exploration, and this is practically skin incision is at the anterior side of the shoulder and starts inferior to the middle of clavicle and extend the lines with anterior border to the deltoid muscle. So anterior deltopectoral approach to the axillary nerve as a part of infraclavicular brachial plexus exploration, following skin incision and subcutaneous dissection. Then you have dissection of the identification of the cephalic vein, and then you have a pectoral major muscle transection. This is classic brachial plexus infraclavicular exploration. Some modifications in terms of minimal invasive targeted approach to the sum of nerve elements are also part of this process. Section of the pectoral major nerve is close to his tendon, and then you now can have this pectoralis minor muscle dissection, which is in concomitant surgical procedure in terms of opening the clavipectoral fascia. Pectoral minor muscle is can be reconstructed, but cannot also sometimes cannot be possible to reconstruct. But pectoral major nerve is mandatory to reconstruct it. Usually it goes easy. Now this is exploration of the lateral brachial plexus cord. We are approaching to our target. Our target is axillary nerve. In this level, origin of the axillary nerve and the musculocutaneous nerve are practically close. So here is identification of the musculocutaneous nerve. And now musculocutaneous nerve is, as you know, origin from the lateral cord of the brachial plexus. And now we are going posteriorly to the, so you see here, musculocutaneous nerve, lateral root of the median nerve and lateral cord. Now we are going posteriorly, and now we identify axillary nerve, which is with its origin from the posterior cord. And you see here radial nerve, which is continuing the relationship with the musculocutaneous nerve. And you see here axillary nerve. So in this, let's say, approach, you can perform this kind of surgical procedure from the viable C5 root grafting to the musculocutaneous and axillary nerve with the sural nerve cable grafting. This is practically a procedure which is appears to be useful with the good results, functional results. But despite of the length of the nerve grafts, which are usually 8 centimeter and longer. So this is through this approach, you can also perform medial pectoral to axillary nerve transfer as one of the transfer procedures to the axillary nerve. These are photos relatively old in terms of our practice, because now majority of our patients are with the axillary nerve lesions are treated via posterior approach and with the usage of the triple transfer, especially in cases with C5, C6 lesion. And this is from the period when we have a series of patients when we use collateral branches of the brachial plexus to the renovation of the functional priorities. This is also possibility for transfer through the anterior approach to the axillary nerve, spinal axillary to the axillary nerve. And as I said, our previous period with the usage of the thoracodorsal and pectoral medial nerve for the innervation of the musculocutaneous and axillary nerve. This photo is that period. That's why it's black and white. And nowadays, we still have this in our armamentarium for the treatment of this patient, but this now predominantly is renervation goes through the posterior approach to the axillary nerve. And in this situation, these are prone body position. Skin incision at the posterior side of the shoulder starts from the inferior of the spina of scapula and extending the line with the posterior border of the deltoid muscle and then staying to the posterior side of the upper arm. Skin incision, which is in the experienced hands, this goes very, very fast and very elegant. Then we have a subcutaneous skin decision. Now we have a retracted deltoid muscle. We have a triceps brachifascia, retracted skin and soft tissues. And now we are going to the triceps brachifascia dissection. It's just, as I said, you can see we are now here through the anatomical planes. So triceps brachii long head, triceps brachii lateral head, then retraction of the long triceps head, then continuing exploration. You see now teres minor muscle. Then we have a dissection of the teres minor. Retraction of the teres minor in terms of visualization of the axillary nerve. This is posterior sensory branch of the axillary nerve exposed. Then exploration of the other branches. You see here quite elegant the dissection. And this is practically end of exploration. Usually there are no scar tissue, no this on this level any kind of injuries, which is marking this. So you have now see anterior branch, posterior branch of the axillary nerve, branch for teres minor, posterior motor branch, posterior sensory branch. So through this approach, posterior approach to the axillary nerve, So-called SOMSAC procedure is doing regularly for the cases C5, C6 lesions in terms of transfer of the radial nerve branch for the medial head of triceps to the anterior branch of the axillary nerve. And this is part of the so-called triple transfer procedure with spinal luxury to suprascapular via posterior approach and Oberlin procedure in terms of reinnervation of the branch for the biceps of the musculocutaneous nerve with the fascicle of the ulnar nerve. In some cases, you can perform grafting to the superior brachial plexus trunk in axillary nerve reinnervation. Then these are usually in the cases with open brachial plexus injury, stab wounds, or some iatrogenic lesions in supraclavicular region. This is also part of the anterior approach, but this is not approach directly to the axillary nerve. This is a supraclavicular approach of the brachial plexus and approach to the C5, C6 roots. So in these circumstances, if you extend this, you can go together with the infraclavicular approach, and then you can go with a reconstruction in these circumstances. So this is one of the dilemmas in this practice in terms of results of the outcome in terms of functional recovery, in the reconstruction of the axillary nerve, in terms of usage of the nerve transfers versus nerve graft in isolated axillary nerve lesions. And these are, let's say, significant differences in functional outcomes between nerve graft and transfer procedure for post-traumatic axillary nerve injuries are not apparent at this time in one of these systematic reviews. And in the other, here the study demonstrates that grafting can result in a good objective functional outcomes, particularly during an earlier time course after injury. So this is a finally question of all questions in brachial plexus surgery and peripheral neurosurgery. Choice of the right method and the right surgical strategy for each individual patient. And this is still ongoing based on the surgical knowledge and experience, since there is a lack of the class 1 evidence based in these circumstances. So this is philosophy of the peripheral neurosurgery: keep it simple, surgeon. And this is the essence of the neurosurgery. And you should cover simply everything what you are doing in terms of clinical history and exam, indications of surgery. Make the surgery simple, avoid complications, and neurosurgery can be done with simple basic instruments. And if you have complications, you have to accept it and deal with them. As I mentioned at the beginning, a group of very devoted people, neurosurgeons worldwide who are doing peripheral neurosurgery, dedicated their time and efforts in terms of reducing these tasks, which are related to the raising of importance and awareness of the peripheral neurosurgery, and providing education to the young neurosurgeons who would like to continue to learn about peripheral neurosurgery in every manner, in terms of online education, like this is, in terms of coming on site, whatever is necessary to settle everything what is necessary for peripheral neurosurgery, or to accept young neurosurgeons for a fellowship in our departments. So this is practically ongoing for a decade, and now more than a decade, and now is still ongoing. So keep calm, raise awareness, and love brachial plexus surgery. These are the series of the events in the Southeast Europe, starting from next week. 6th Congress of Southeast Europe Neurosurgical Society in Budapest. Major event neurosurgical in Europe this year. ENS, European Association of Neurosurgical Societies 2024 Congress in Sofia from October 13 to 17. And last but not least, in this series, 10th Serbian Neurosurgical Society annual meeting with international participation related to the pediatric neurosurgery, which is October 31st to November 3rd in Belgrade. All of these events are full of peripheral nerve surgery, so I cordially invite you to come to join if you are in the situation. And this is my mentor, Professor Miroslav Samaric, who's merited in making Belgrade visible in the world of peripheral nerve surgery. Is of outstanding importance. We are friends. He is still active, not surgically, but academically. His shape and look is the same like you see in the photos, and you can see me now. This is a photo, is my favorite because life is not fair. Somebody looks the same, somebody is changing. So thank you very much for your attention. Of course, I'm happy to answer to all of your questions if there is any.
Thank you very much for this very clear and educative talk, Lukas. Any of the assistant questions from the audience? No, I cannot see any question. So
there are some comments in chat. Let's see.
Where?
No.
No.
These are
we're just asking for your email.
Okay, these are some only comments. Okay.
Only comments, yes. So I think as you said before, Lukas, the importance of being familiar with the anatomy of the axillary nerve, as this is one of the most important targets after a brachial plexus injuries. I mean, targets for reconstruction. So I think this could be very useful for the rest of the surgeons. So I would like to ask you, Lukas, you showed before one slide regarding the use of grafts or nerve transfers for the reconstruction of isolated injuries. But what is your experience exactly with this topic? What do you prefer?
For isolated injuries, which are clearly defined that they are, let's say, distal in terms of origin.
Mm-hmm.
Maybe if you can, let's say, identify proximal and distal stump in this situation, which can be in some situation, grafting is quite good. But from the proximal lesions, in some circumstances, transfer is always better.
Okay. We have one question from Ibrahim. What is your question, Ibrahim?
Ibrahim, have a question.
Yes.
Can we hear the question? Or you type the question? You type the question.
Ibrahim.
While we wait, may I ask you something?
Yeah, Mariano.
Yes, Marian, please.
First of all, thank you very much for this wonderful talk. You really review very nicely all the anatomical approach and the anatomical nuances of this important nerve. Regarding pectoral to axillary nerve, you and yourself and Professor Samarczyk were both pioneers in this technique. They are really original descriptors. So I want to know which is your experience regarding the donor pectoralis minor. Which is the branch, because as we all know, and as you pointed out in your talk, there are many pectoralis branches, both coming from lateral and medial. So you can find many. Which is your criteria for selecting the donor in order to avoid damage to the rest of the and especially to the adduction?
Well, this is a excellent question. Thank you, Mariano. This is something which is in terms of consideration and preoperative evaluation. Let's say before we become aware of triple transfer, we, as you said, we are pioneers of this. Let's say collateral branches to functional priorities of the brachial plexus approach. And I have to tell you that this is something which is very good in terms of outcome, especially when you use it in the usage of thoracodorsal nerve. Medial pectoral nerve also can give a good results, but in some circumstances, the outcome can be weaker than when in thoracodorsal nerve you have practically 100% excellent outcome. In medial pectoral nerve, you don't have such good functional outcome, maybe around 60 to 70% of cases, and the quality of recovery is, let's say, not such good as when you use a thoracodorsal. But still, in terms of let's say choosing this criteria in terms of usage of the pectoral medial nerve, nowadays if we have a clear situation, I'm always using triple transfer. But if some situation requires usage of the pectoral medial nerve, then I collect ANSA or all branches which are making ANSA of the pectoral medial nerve and then put it in one, let's say, stump. I made some modification with the fibrin glue and collect all of them and make a practically nice proximal stump. And usually it is good, long enough to make a direct coaptation with some of the functional priorities. So choosing of the pectoral medial nerve, in my opinion, it's let's say second line of the choosing of the in the armamentarium, in the let's say army of everything what we have as on the, if we don't have possibility to choose first line of the priorities, then first line of the donors, then we use pectoral medial nerve in these circumstances. So this is something which is I try to explain. If I hope it's clear to everybody. I mean, surgical approach to the pectoral nerve through the infraclavicular approach, when there is no scar tissue, it's easy. And then it is thoracodorsal and pectoral medial nerve usage in terms of nerve transfer. When there is no scar tissue in terms of deltopectoral region, is anatomically very easy, like posterior approach. You go directly to the plexus, and then you find thoracodorsal pectoral medial nerve functional priorities. You make this coaptation very quickly and very elegantly. If there is a scar tissue, there is then a lot of challenges in terms of identification, all of this. But still, pectoral medial is not the first line of donors. Is second line, and it's used always in the situation when you cannot use any kind of donors from the first line. And in some situation, for example, when you have a preserved part of the C7 and in the, for example, C5, C7 lesions, when you have preserved part of C7 and you intraoperatively verify that pectoral medial is working, and you don't have any other possibilities for some donors, then you can use pectoral medial in renovation of some of the functional priorities. Still, expectation for the final outcome is, let's say, not quite good, such as when you use a thoracodorsal nerve or any other nerves. And
thank you very much. Yeah, it's clear. Yeah,
thank you, Lukas. Well, we have two more questions. The first one from Mustafa Abu Shihata. His question is, does spinal accessory transfer to suprascapular enough for shoulder abduction, or axillary nerve should be reinnervated too?
Can you repeat one more, please?
Okay. Does spinal accessory transfer to suprascapular, I mean, this transfer is enough for shoulder reinnervation, I mean, for abduction, or axillary nerve should be reinnervated too?
In my opinion, it's not enough. Spinal accessory to suprascapular is not enough for the shoulder abduction. It ideally is to have both spinal accessory and the reinnervation of the spinal accessory to suprascapular and that reinnervation of the axillary nerve in any manner. But this is in comparing. This was also some papers about comparing, is the spinal accessory to suprascapular enough or better in order to compare with the isolated reinnervation of the axillary nerve. And in my opinion, if I have to choose, should I reinnervate axillary nerve or suprascapular nerve for the terms of shoulder abduction, I will always reinnervate axillary nerve. Ideally, reinnervation of the both is a winning combination.
Thank you, Lucas. The second question from Ibrahim, and maybe I don't know if you, Imad, can enable the audio of Dr. Ibrahim. He's asking for this, but anyway, the question is, do you prefer long head of triceps to axillary, or medial head of triceps in upper trunk brachial plexus injury?
This is practically more or less slight differences. You understand me? Not big differences in terms of if you choose one or one or second option. What Ibrahim mentioned. You understand me? This is not a big this. I personally use the medial.
Okay. And what about you, Marian?
Well, I usually prefer either the medial or the lateral.
Or
the
lateral.
long, yeah, yeah, one of the two. The procedure was described by Somsak as using the long thoracic, the long triceps branch, but since it also gives some stability to the shoulder, tracking from the triceps, maybe at my experience, maybe it could affect likely the stabilization of the shoulder. So that's why in pure isolated axillary injuries, I prefer to use either the medial or the lateral.
Same from my side. Long head, I avoid.
Mm-hmm. Okay. Okay, one more question from Ekapot Jitpun. In medial pectoral nerve transfer to axillary nerve, does the patient has the problem with training, since it seems to be antagonistic in function?
This question is more for Mariano than for me, but
I'm happy that this question is done in this anatomy
this is
webinar. I'm very happy. Thank you, Eka. Thank you. I was not doing the question.
This is related to the brain plasticity, and if there is some possibility for this reorganization, you can expect some nice results. If there is no, there can be a, let's say, lower functional recovery in this situation. But this is something you are doing this only when you do not have any other possibility to reinnervate the axillary nerve. I think, Ekapot, we are clear about this. This is not that we are doing like a standard procedure.
And maybe that's why you, after many years and after describing this technique median to axillary, you put Lucas yourself your technique as a secondary line. Maybe because brain plasticity is involved.
No, exactly. That's completely clear. I mean, that's completely evident. I mean, results in functional recovery of our patients show this, and that's it.
Yeah, there is a very recent publication by Marcio Mendoza from Brasilia, a colleague here from South America, who analyzed very carefully his results regarding medial pectoral to axillary. And since they are antagonistic, this was published a couple of weeks ago. Since they are antagonistic, their results, according to them, are not so good.
Agree, but as I said, this is something what we are. For example, this is what we are doing only in the, let's say, worst case scenario. You understand me? This is not.
Yes, of course.
So same goes to the pectoral medial to the musculocutaneous nerve. Same story. You understand me?
Dr. Lukas, thank you for this excellent presentation about axillary nerve. I ask you about the difference between long head of triceps transfer to axillary or medial head of triceps. Is it a difference? Is there a difference between?
We answered that question. Maybe you didn't hear. We have a comment together, Mariano and myself. So your question was, do I prefer long head of triceps to axillary?
Is it a difference in the result?
No. Long head. I avoid long head. We discussed. I avoid long head. I usually use medial head, branch for medial head.
Because by my prof, Dr. Bandari, you know Dr. Bandari. I trained on brachial plexus with him, and he accustomed to take a long head of triceps only, and not medial head of triceps.
Once again, repeat once again, please.
He said
Dr.
that
Bandari, Dr. Prem Singh Bandari, my professor. I trained on brachial plexus injury with him.
Okay.
And he accustomed to take long head of triceps branch and not medial head. Because long head of triceps is very near. After sectioning of the teres major, lower border of teres major, you can catch the long head of triceps easily.
That's okay. I mean, this is fine. Generally speaking, you can make this cooptation with all three branches. This is not the problem.
Yeah.
The question
but
is,
there is no difference in the result. As regards the result,
I didn't compare long results of functional recovery with the usage of the long head, because I rarely use long head. I didn't practically. I do not remember when I used long branch for a long head. You understand me? So in regards of function of the triceps muscle, there is some kind of opinion that the long head is a stabilizer of the triceps muscle. You understand me? Medial and lateral are also important for the function, but long head is very important for the triceps function. So that's why we are not taking a branch for the long head. And if you take one medial or lateral, this can be compensated in terms of let's say, reorganization of the long and medial or long and lateral head, in terms of have a good elbow extension in this situation. This is the reason why we are not using long head. Maybe Jamie Bertelli have some other ideas. In my opinion, it might be that if you use long head, only long head, and leave lateral and medial, it will not affect too much elbow extension. But my experience is always with medial, sometimes with lateral. And if some days experience with long head shows better results in terms of functional recovery, I don't believe, because these are similar results in terms of recovery of the elbow, of the arm abduction. But the question is the quality of elbow extension after the usage of the long head.
As second comment, I ask the committee for thoracodorsal anatomy.
Once again.
Thoracodorsal anatomy.
100%.
No. I ask the committee
family,
to prepare for preparation of a lecture on thoracodorsal anatomy.
So thoracodorsal anatomy is a pure motor nerve. I mean, there is originating from the posterior cord. This is nothing special in this.
No. I ask the committee for a preparation of a lecture on a presentation on thoracodorsal anatomy. I need.
So you need a talk about the anatomy of
talk. Yeah.
Right. Okay.
Preparation of a talk about it. And also the previous presentations to be sent on our email.
Okay.
Yeah.
I don't know who is handling this, but Mariano knows who is handling this. You have this on what is recorded previously. I hope this is recorded, and then you can take it very easily. But for the thoracodorsal anatomy, I think you will be the ideal volunteer to make this presentation. Since you are interested.
No. I can't. I ask.
You do your best. You do your best to explore this.
I searched for the anatomy of the thoracodorsal in the literature, but I didn't find a strong source for thoracodorsal anatomy. So I asked you.
No, you are invited to participate as a speaker. So at the end, we can add your talk.
In another
still some
topic,
months. You still some months for dissection.
Okay, well, if no more questions, and if you are agree, Lukas and Marian, I think we can conclude this webinar, this very educative and clear and interesting webinar about the anatomy of axillary nerve.
No, I'm very happy that I don't know how many participants, 28, now 27.
27.
The maximum was 30, near 40, 30 something.
Okay.
So it's very good. It's a very good participation.
Fantastic.
Congrats.
Okay.
Nice initiative. So we continue with this series of webinars and see each other very soon. I mean, during this month in Sofia and Torino.
Exactly. So
thank you.
Bye.
All the best. Bye.
Have a nice day.
Bye.
Bye.